endocarditis, therapy of native wall endocarditis caused by Staphylococci. In previous lecture, we seen the treatment of streptococci. Now we will see the endocarditis caused by Staphylococci in the absence of prosthetic materials. Yes, let us see. Native wall endocarditis caused by Staphylococci. The most common bacteria from the group of the Staphylococci is Staphylococcus aureus, which is also coagulase positive. Coagulase is an enzyme produced by the bacteria Staphylococcus aureus, and that is responsible for the blood plasma clot. The coagulase positive bacteria is always considered pathogenic, causes severe invasive infections like the skin and the soft tissue infections, pneumonia, bacteremia, sepsis, infective endocarditis, and osteomyelitis. While coagulase negative is the bacteria from the group of Staphylococcus, and the name is Staphylococcus epidermidis. And second bacteria is Staphylococcus lugdunensis. The coagulase negative Staphylococci these are often contaminant. It is by the contamination, and frequently due to the blood culture contaminants, and these include this infection, or we can say the true infections usually associated with prosthetic wall, catheter, implants, or shunts. And here, if the bacteria is the coagulase negative, then the first line treatment always the vancomycin, because coagulase negative may be methicillin resistant Staphylococcus aureus. So here we may also consider the vancomycin the first line agent. The drug of choice for the Staphylococci infection and native wall is napsilin or oxacillin. The adult dose is 12 gram per 24 hours intravenous in 4 or 6 equally divided doses, and duration of treatment is 6 weeks. The pediatric dose is 200 milligram per kg per 24 hours intravenous in 4 to 6 equally divided doses, and duration of treatment is 6 weeks. There is one remark: for complicated infective endocarditis, the 6-week treatment And for uncomplicated infective endocarditis, we need to give 2 week treatment. Complicated infective endocarditis includes cardiac complications like the heart failure, wall perforation or rupture, AV block, sometimes embolic complication like stroke, renal infarction, pulmonary embolism, and sometimes uncontrolled infections like persistent bacteremia more than 5 to 7 days despite of antibiotic. Then also neurologic complication like the stroke. So if there is an infective endocarditis, then we need to give 6 week treatment. So the most commonly or preferred drug or first line drug is napsilin or oxacillin. We need to give one as per the availability. In napsilin or oxacillin, we need to add gentamicin, and this is an optional addition, and remark is no clinical benefit. Gentamicin sulfate, gentamicin is, it's an mycin, remember gentamicin, it's not mycin. It's an aminoglycoside antibiotic. Adult dose is 3 milligram per kg per 24 hours in 2 to 3 equally divided doses, intravascular or muscular. And duration is only 3 to 5 days. Pediatric dose is also 3 milligram per kg per 24 hours in 2 to 3 equally divided doses, intravenous or intramuscular. But if the patient has autotoxicity or nephrotoxicity, then we need to contraindicate gentamicin, because gentamicin is responsible for the damage to the or impairment of eighth cranial nerve or renal function failure. So we need to avoid gentamicin. So the first line agent for staphylococci, if the bacteria is gram positive or gram negative, we need to give napsilin or oxacillin with optional addition of gentamicin. Now, what about if the patient has penicillin allergy? Because napsilin and oxacillin, these are the from the class of family of penicillin. And this penicillin allergy, which allergy? Mild allergy, or we can say non-IgE mediated reactions to penicillin. Remember, non-IgE. And if the non-IgE means delayed rash, or we can say upset stomach, gastrointestinal upset, then okay, we will give cefazolin. Then it is okay to give the drug from cephalosporin. And this drug will not cause delayed rash or gastrointestinal upset like napsilin or oxacillin. Cefazolin, adult dose is 6 gram per 24 hours intravenous in 3 equally divided doses, and duration is 6 weeks. And for pediatric, 100 milligram per kg per 24 hours intravenous in 3 equally divided doses. Duration is also 6 weeks. And it's very important. The 6 weeks duration is for infective endocarditis, which is complicated, which is complicated. And note, cephalosporin should be avoided in patient with the hypersensitivity to beta lactams. Yes. Now, which hypersensitivity? If there is the IgE hypersensitivity, IgE. What happened in the IgE hypersensitivity? Anaphylaxis, angioedema, bronchospasm, and hypotension. Then we need to avoid cephalosporin as well. And same with optional addition of gentamicin sulfate. Gentamicin, it is not mycin, not MY, it is MI, gentamicin, because obtained from Monospora purpurea species. That's why. Aminoglycoside antibiotic, yes. Dose is same as we previously discussed here, 3 milligram per kg, and duration is also same, 3 to 5 days. But what is the contraindications? Look for the ototoxicity and nephrotoxicity. So this is the treatment of native wall endocarditis caused by Staphylococcus. The first line drug is always napsilin or oxacillin. And if the patient has mild allergy, then we need to go for cefazolin. And duration of treatment 6 weeks. And there is no benefit for gentamicin. But if we add the gentamicin, uh, the benefit is that maybe the two mechanism of action, because napsilin act via inhibits the bacterial cell wall synthesis. Oxacillin also inhibits the bacterial cell wall synthesis. Cefazolin, from the category of cephalosporin also inhibits the bacterial cell wall synthesis. So the gentamicin inhibits the bacterial protein synthesis. So we will get synergistic mechanism of action, and that's why maybe it will benefit to the inhibition of the to inhibits the bacterial load. So if we are adding the gentamicin, take care about the ototoxicity and nephrotoxicity. So this is about the oxacillin susceptible strain. What about oxacillin resistant strain? If the Staphylococcus aureus SA, which is oxacillin resistant, or we can say methicillin resistance, both are same. Oxacillin or methicillin resistance means these bacteria, MRSA, this bacteria is not killed by the napsilin or oxacillin or penicillin. It is resistance to the oxacillin. In this case, the drug of choice, or we can say gold standard, is vancomycin hydrochloride. We can say it's the gold standard for treatment of oxacillin resistant strain of Staphylococcus aureus. We can say MRSA, MRSA, methicillin resistant Staphylococcus aureus, the bacteria which is not able to kill by the napsilin or oxacillin. The adult dose is 30 milligram per kg per 24 hours intravenous. in two equally divided doses. Duration is 6 weeks, and for pediatric dose 40 milligram per kg per 24 hours intravenous in 2 to 3 equally divided doses. Duration is 6 weeks. And the note is 1 hour peak serum concentration. After giving the dose intravenously, after 1 hour, the serum concentration after 1 hour will be high. So vancomycin is the drug of choice for the MRSA, oxacillin resistant strain. And also if uh, the bacteria is coagulase negative, if the coagulase negative, we also need the vancomycin hydrochloride. So these are the drug therapy for Staphylococcus, the Staphylococcus aureus SA, and if it is uh, native wall endocarditis, native wall NVE, then we need to remember the duration of therapy is 6 weeks. The drug of choice, as we seen, the drug of choice is napsilin or oxacillin, and if there is any resistance, then we need to go for vancomycin.